Hi, everybody, and welcome back to the Blueberry Pediatrics Podcast. I'm your host, Dr. Lindsay Garby, CMO, Blueberry Pediatrics, and a board-certified pediatrician. On today's show, we have Dr. Tracey Green. Dr. Tracey Green is a compassionate patient advocate and transformational change agent who understands the importance of physical, behavioral, and social determinants of health, along with data-driven decision-making as drivers of community and population health programs. Dr. Green has held numerous senior leadership positions throughout her career, including Chief Medical Officer for Aetna Better Health of Nevada, Vice Dean of Clinical Affairs at the University of Nevada, Las Vegas School of Medicine, and served for 7 years as Chief Medical Officer for the Department of Health and Human Services for the state of Nevada. In this role, she received recognition for her innovation and healthcare delivery for children. Dr. Green led the state to creation and ultimate passage of a comprehensive telemedicine law. In her role as CMO, Dr. Green and her team wrote and implemented telemedicine across the state. She serves as VP of Clinical Innovation and Product Development in CareSource, Nevada, and the Clinical Medical Director for Integrated TeleHealth Solutions located in Nevada. She attended the University of Nevada, Reno, earning her Doctor of Medicine degree from the University of Nevada School of Medicine as a board-certified family medicine doctor. Welcome, Dr. Green. Thank you so much for joining us.
Good morning, and thank you. Happy to be here.
There's so much to talk about. I would love to hear how you started out on your career pathway.
Well, it is an interesting story. I will say, I graduated undergrad and I thought I was going to be a linguistic psychologist. And so I came to Nevada to work with Washoe the chimpanzee. Her mom was Washoe, and Washoe taught her babies sign language. And I came here to be a data analyst. And what I learned when I got here, and one of the points I really want to make is I think relationships have sort of driven my career, because while I was here, I met some licensed clinical social workers and some psychiatrists, and really became more interested in the clinical model than the chimpanzee model. And so I then went to work for UNR, the School of Medicine in Reno, and ultimately applied and went to medical school here in Nevada. So that really started my career, and did private practice for a long time after that. And then after I did private practice, I was supervising the rural clinics here in Nevada. And the director at the time was the chief. And he asked that I consider taking the CMO job at the state. And so long story short is I did public health for almost 9 years with the state. And then, as you mentioned, I went to the University of Nevada School of Medicine in Las Vegas, and have progressed since. Really, I think the career change when I went to managed care, I felt like that was going to be the best way that I could impact healthcare here in Nevada. So the last portion of my career has been in managed care. I've worked for 3. Currently, I'm with a nonprofit managed care called CareSource, and just love it. Different theory, different thinking, different investing. So really happy to be part of CareSource now.
Wow. So within your role and impacting population health, what are the things that also attracted you into that space? And where is the biggest change able to be made that you want to jump into?
Right. Well, one of the things I've from a multiple different levels, I've tried to impact healthcare here in Nevada. So university approach, private practice approach, and what I've really seen is that when managed care was introduced, and I primarily work in Medicaid, I should say that. Most of my career has been in the federal programs, so I stay on the Medicaid, Medicare side, but I'm really primarily Medicaid. And so to move the dial in Medicaid, as you know, is very challenging. And so the key is the deliverer of the medical services, because they carry the rules, they carry the benefits, they carry the products. And so for me, it was really, I realized that to impact healthcare, I'm going to need to be part of the provider payer system. And in that mode, I think I'll have the most impact. And I will just add, I think social determinants of health is probably the key that drew me through CareSource, but also through managed care. Because what you'll see now is that Medicaid is moving to provide the responsibility for social determinants to the managed care plans that are providing the health care. And so for me, as I saw this shift to managed care becoming responsible for social determinants, I knew I had to be in that realm to actually impact the healthcare.
Gotcha. So I'm going to go back a tiny bit. The practice you had in private practice, the knowledge you gained from that, how have you applied that into this new role?
Really interesting. I think the biggest key, and again, going back to relationships, I was very focused on behavioral health in my private practice. I found that there was an absence of providers for the LGBTQ community. And so actually in my private practice, I specialized in transgender care for youth and adults. And so in the practice, I became really a BH social focused primary care doc, meaning I did all the other primary care, but I really became focused, and populations were attracted to come because we became specialized in doing really those social needs, taking those individuals that really need additional help. So my practice became serving the population that I serve now. And trajectory, natural trend, my desire to help the population, not really sure, but really had a very heavy Medicaid population at the time, a lot of public service. So that carried over. The part I wasn't able to do in private practice, though, the influence of the system is what I missed.
Yeah, that makes a lot of sense. So in your private practice, if you focused on behavioral health and social determinants of health, were you able to, how much were you able to do all of that? It's a doctor's office. I think there must have been limitations that, unfortunately existed.
Yeah. Well, it really changed. So I was in private practice for 12 years. And I'd say the first 5 years, I did traditional family practice. And then it was a trajectory over time that changed as there was less and less providers in that niche. And so while I had 100% of what I would call primary care, it went to about 60-40, where I was doing much more of the behavioral health social and much less of that sort of acute chronic primary care. Although I did still have that 40% of my population, and of course, any individual that had BH or other issues, we were caring for them holistically. The other thing that really helped was the partnering with the federally qualified health centers and with, we didn't have CCBHCs at the time, we do now, but really
Can you break that down, CCBHCs, for listeners? I don't know that everyone knows all the acronyms that we're throwing out. No, even I don't know all of them. Say that again, I missed it.
Yeah, and so partnering with them and partnering with some of our centers here, that's how I was really able to do it all. But you really saw the trend of my practice move more towards that and away from the traditional primary care.
Okay, so you had support, or how did you even find it? How'd you know where to go for that?
Yeah, I met a mentor actually who was a psychiatrist here in town. When I was doing the work with the chimpanzees, for whatever reason, they were a group of psychologists, but they introduced me to a lot of psychiatrists. And so it was through the psychiatrists locally that I was able to partnering with surgeons, so it was definitely a partnership and a team that we used. But, it's never one entity. It was a lot of referral, a lot of the issues around food insecurity. I like to get people into WIC and SNAP and all the programs that are available. So there's a lot of alignment with programs that existed, but definitely not alone, and definitely not we did the best we could.
Yeah. So I would assume this then informed so much of what you then did on the other side of things in your other roles. I would love to hear about what you focused on in those roles and how you were able to make a lot of these changes that you were passionate about.
Interesting. So when I thought, it's kind of funny because I thought that if I went to the School of Medicine, we had a school in Reno and we got a school in Las Vegas. And I thought I could take the trajectory of what I'd been working on around public health and bring it to academics. didn't exactly work out that way. It was a much more traditional academic program when it started. And so expanding, we were already, this was about 2015, 16. We were already talking about social determinants. We were already looking to address social determinants.
Yeah.
The schools weren't quite ready. They were building a very traditional medical school. So that wasn't going to be the venue for what I needed. And that's my next step, was getting over to Aetna and actually serving as CMO here after we won the bid in Nevada. So then it was really easy, because then it was everything that I was trying to impact. But it wasn't happening at the university level, and it wasn't happening in private practice. I could not bring together enough to affect change.
That's actually really interesting that the academic university side was behind, or you were just so ahead. Do you feel like they've caught up, like the academic side right now?
You know, I don't think they've really caught up yet. I would say that, there's a standard curriculum, and I get it. You got to pass the boards, you've got to do everything. And unfortunately, the boards haven't merged into the social side as much as probably they will in the future.
Right.
So you got to pass the boards. So you got to prep for the boards. And I get those. But you're right. I mean, they just were not looking at social needs. I think it was too big. And it's huge. And so biting the elephant in small pieces is critical. But no, they were more trying to get the class to qualify than they were really expanding beyond the traditional boundaries.
It's actually something I've never thought about until now, about how med schools, I don't know if what they're doing exactly, so I can't speak to that well or informed, but I would hope they are implementing the social end of things, and what we get, or even the business end of things, like what we're getting tested on. And now with all like ChatGPT and all these things that can like tell us answers to like a pathway in the metabolic like breakdown. But nobody can, you can't look up how to navigate a health system exactly, and how to formulate relationships and how to meet patients where they need to be met. So I would hope they're doing that a little more now.
Lindsay, it's interesting because CMS, the Center for Medicaid and Medicare Services, is going to manage care to drive social determinants as opposed to going to universities. And that may be why we are now able to, because of a program that's being established, provide housing, provide food. And really the thought is, if we provide housing and provide food, you won't need to go to the hospital as much. You'll
Absolutely.
be healthier.
Right.
And if you're fed, you won't be worried about eating, so you can take care of your health. That's what we're hoping is the outcome.
So this is coming from a federal end to really push these initiatives. Yeah.
Yes. And they're coming in something called in lieu of services, which is really too complicated. But what it means is, in lieu of going to the hospital, we're going to try to give you food and a house, and let's see if that makes it better. And that's literally the in lieu of. It's saying we can prevent this if we give you these, and they're all social needs. And so it's exciting time, because now as CareSource, there's money in Medicaid to help provide housing. Now, again, we're not paying you rent for the rest of your life, but we'll make it so that you can get the down payments. You can get the landlord. We can help you with a job. We can help you with disability if it's appropriate. That whole comprehensive program is now being given to managed care for Medicaid. So that's an exciting part for me. Now, again, we can start impacting care.
And so there are programs that you partner with who jump into like organization of all those aspects of things, like getting food to the home, meeting patients where they are. How does that work logistically? Like, how do you get them the food, and that takes so much, I would say, person power.
It's crazy. So I'll give you a great example. Michigan currently just implemented, again, it's called an in lieu of for food. And there's two kinds of food. When you discharge from the hospital with a medical condition and you don't have food that's appropriate for that condition, it's food in that circumstance. And it's also, if you're hungry, we can send you a series of food boxes. So What we have now had to do is meet with the organizations that provide food and food boxes. The requirement is that there's a dietary assessment and an evaluation. So we're partnering with dietitians, partnering with food providers. It's big.
Hmm.
It's big. And again, this is brand new, first time in implementation. So it'd be great to see, but that's the goal, is we're getting multiple local and national food companies incorporating an assessment process. They go through then the docs who say you need 6 months or 12 months. And that's a real soft point right now, is how long. And then we start going with the vendors that provide food.
So I was just at the HLTH, the health conference in Nevada, in Las Vegas, and I saw a few companies who are doing this, bringing the boxes of food to the home. And I thought, that's incredible. And at the same time, how can they sustain this? Because outcome measures are so difficult to measure and really won't be seen for years and years to come. So how is there incentive to even start a program like this when, I mean, at least from the little bit I've learned, like if there's not immediate return on investment, it's very hard to convince people to invest in that field or in that area. And in this case, getting those boxes of food home. So how's that going?
Well, it's all new, so I will give you some conjecture and some thought and what we've seen so far. We have value-added benefits essentially on the Medicaid side. So we've been doing post-discharge meals for a while, just not covered by Medicaid. So there's a couple things. One is we get earlier return, and I believe it's because of the relationship. So if you have not been accessing care because you've been hungry and you haven't been able to get any help, all of a sudden you've got a case manager who comes to you and says, we're going to help you with food, but they don't stop there. So they also discuss what other issues are going on and what's happening. So I think it's not just the food that we're seeing. It's really total cost of care, Lindsay, that we see a change in, because
Okay.
one less ED emergency room visit, that's a big change for us in cost. So there's more to than just the food. So there's the interaction that occurs. But again, the purpose of the program is to then say, do you need a job to sustain this? Do you need WIC and SNAP to sustain this? Do you need disability? Do you need another pay source? And if so, the goal is not to have you survive on weekly supported food boxes. It's to then address your total circumstance and see what is a sustainable model for you to have food forever based on income and everything else.
Yeah. I mean, it sounds great. I really hope it works.
Me too.
And that I think it takes an investment. I mean, clearly a lot of the investment is being made in people. I hope the people make an investment in themselves too and use this to the best, outcomes possible, because it's so, I think, groundbreaking for what we're doing here and really taking care of everyone, how they need to be taken care of.
Well, what's interesting is you bring up a really good point. I know we talked some about health equity. And one of the things when I think about health equity is we're trying to create an opportunity for everybody to have equal chance to improve and be better. But then there's human choice. And so we really have to learn more about that. Is it going to be that we just set the stage where everything is available? Because that's not what I see, especially not in smaller rural communities. They're pretty ingrained in their behaviors and they've learned to adjust. And so, it'll be interesting to see if providing these benefits does more or not.
Right. So we probably will learn more about human behavior and other kinds of needs that could better suit a certain population. And yeah, that's so interesting. I'm so eager to see where this goes over the next several years.
Great.
But
Love to
I
work
do,
together.
yeah, I definitely, food is like, I think just even the beginning of it, healthy food, like makes healthy people. So that's great to hear. Yeah. So can we talk more about health equity and all your
Sure.
experience? And yeah, it's a great topic for Nevada, especially because of the diverse population. Can you tell me about the population itself and all that you've learned?
Yeah, Nevada is very interesting. I will say that we used to be predominantly white. We're now very much a white and Hispanic population. Predominantly, we are now the eighth island. I think it's eight, might be seven for Hawaii. So we have many Hawaiians that have moved to our communities as well.
Is that a
And
term used frequently for
yeah,
like Hawaiians who move out of like the actual island of Hawaii? I've
that's
never knew that.
correct. Yeah,
Oh,
and we have a Hawaiian embassy, sort of a place
very cool.
where, because, obviously it's us, but again, there's large communities. Our CEO is also Hawaiian, and she came from
Oh,
Hawaii, and her name is Jamie Pu'u. And so we're really excited, to have representation because that's what it takes. In our community, I would say that everything is siloed. I would say that birth outcomes are scary,
oh yeah.
and most of it is because of inequitable access, period. Either it's not there or they're not going. We're doing some interesting things. We're hoping to come into Nevada as CareSource, and we're doing some interesting things because one of the things we're worried about is we're concerned that pregnant women are fearful, and so perhaps they're substance using and they're fearful they're going to have their baby taken from Child Protective Services or they're undocumented.
The chills,
So
yeah.
we're creating some OB safe zones to kind of
Wow.
try to help people. Because we've seen that's another thing in our community. There's a lot of governmental fear. They do not want government coming into their lives and taking over.
Wow. That is a lot I don't even know how you start to break into that. So how do you turn them into trusting or accepting of the help or, knowing that a hospital is a safe place to have a baby and optimize outcomes for births?
Well, the first thing you have to do is make sure it is. Because
Oh,
there's
okay.
validity to a lot of what's happening out there. Discrimination is real.
Mhm.
So I'm a big, investigate, get all the data, figure it out, and then go in to try to. And our approach to communities is not to supplant, but to support. So we want to enhance a community's capacity, not supplement. We don't want to be that organization that comes in, drops a big clinic, we go and the clinic goes. Like that is not our model at all. So
Mhm.
we're really trying to get into the communities to learn by community, especially because the goal now is to expand Medicaid to the rurals. We have 17 rural and frontier communities. So we're really focused on learning about the communities first before you offer anything. And that's the phase we've just completed. Um, did about 2,700 miles through rural Nevada. Really interesting and exciting. But I will tell you, that's the way to start. They will not trust you if they've never seen you and you're just an entity plopping around. That doesn't work. And so we believed, and I really believed, that it was going there, seeing the communities, being a part of them, offering and listening. What do you need? Many communities don't even understand their problems, but they don't want some of the services we provide
Oh,
because it's pseudo government.
right. So I mean, my background's pediatrics, obviously. So what is it like for care for kids in these areas?
Well, it's very challenging. We are under a DOJ suit for behavioral health care for children because the outpatient community-based services are very limited. And so what is happening
Limited
is
because of there's no doctors available or like there's no funds to create clinics? What's the barrier there?
I don't know that it's funds to create clinics, but it's more we don't have the outpatient child based services. So we don't have many providers. We do have a residency for child and adolescent psych, but we don't have many specialized clinics at this point. And the biggest thing for me, there's no system of care for these kids. So you may get a psychiatrist, you may not. You may get a psychologist. It depends what door you enter here. And then your whole trajectory is based on the door you enter because it's so siloed. And so the DOJ said, unfortunately, that our children were in residential when they should have been either discharged and or served in the communities. And so we're building community-based services here, but it's been very, very challenging for children and young adults. Um, So, that's the other thing is by bringing the rurals to managed care, we'll also get the kiddo population in managed care. And honestly, it's why I love Blueberry. And I think you guys know, I just think, what you offer, just to have some security and competent resources. Part of what happens is you get into a system and you have what you have. And so we give choice now to have an option. And that's what we need is we need more options. We need more providers, and we need an integrated system so that our kiddos don't get lost in someone's silo.
Gotcha. That's a lot to take on. How does like a medical plan or payer system, how do you establish that?
Well, one of the things that we're looking at is behavioral health homes. So really kind of changing the structure of how, we saw patient-centered medical homes front door for what we see as physical health. So maybe what we need to do is convert now to more of a front door for kids and families with primary behavioral issues, social issues, and then wrap everything else around them. So that's the approach we're trying. We're going to try to focus on the primary issues. And if they're behavioral health, then that's your primary team. You still get all of the EPSD, you get all of the other kiddo services. You still have a pediatrician. It's just you have a child, either psychologist, psychiatrist, therapist, autism provider, ABA, whatever your needs are, you'll have somebody in that genre as well. So your leaders change by your needs, not our needs.
And how are you thinking about data and technology's role in addressing these health disparities and delivering these personalized care into to these Medicaid members?
Yeah, so data. Look, everything, we need data, and state data, federal data, really, that's a big challenge. So the first thing I would say is we all have we have health exchanges for information.
Mm-hmm.
We call them HIEs. We don't use them. We don't use them because they're expensive. We've got a million excuses. My suggestion, and we're going to try, is if we incentivize to use, so what an HIE does is it gathers all of the data about people as they traverse through any system of care.
Mm-hmm.
If we're going to try this HIE approach, let's try it and do it all the way. So figure out a way. All providers need to enter their data. We've got to figure that part out, because if that's going to work, it can really help us. If not, we've got to internalize a lot of this, and then we're going to have siloed data systems. So I'm a big fan of supporting HIE and then centralizing data opportunities. So I think all of the managed care, because there's going to be 4 or maybe even 5 of us, we need a central state-based way to gather data. We don't have that today. The state would love to see something like that. But we've got to move to where data can be shared so that as members move around, which people naturally do, we don't have to restart the wheel. Mm-hmm. So those 2 things, I think a centralized database in the HIEs, if they will work and people will participate.
Gotcha.
It's such a waste if they don't.
Yes. If they don't. Yeah, absolutely. Are there plans in motion to get that off the ground?
Yeah, there's discussion on whether at some point they'll contractually require you to be a part of the HIE.
Who's they?
The state Medicaid for the Medicaid providers. Okay. They have an arm to make that possible for their providers. Theoretically, Medicare could do it for their providers. There's just not there's not a group overseeing physician practice models per se. So even though there's groups of docs, they're not driving things like data and practice models and things like that. Would love that, but we don't have anything like that.
Right. Okay. Gotcha.
So and we go into Medicaid, we go into Medicare, we pull down population segments that we can impact. And that's about, that's where I come to it. And then we'll have to figure out the rest.
Is there, so you haven't been able to pull any data thus far to figure out exactly where to implement new programs, or are there new programs and initiatives you started with already or have been started within the state already?
Little of both. There's some data, every plan has their own data. So we have some data I think the way we start, so I'll focus a little bit on rural Nevada because that's what we're working on now, is to expand our product into rural Nevada.
What like percent of the population is rural?
About 16%.
Okay.
There's 75,000 Nevadans living in 17 rural communities. And we have about, those are eligible Medicaid. We have about 800,000 total Medicaid members. And of
Wow.
that, 70,000 are in rurals. So just under 10% of the Medicaid population, but then there's other people living in rural Nevada.
Okay. Gotcha.
So rural Nevada is just now introducing, and I think it serves as a great example for your questions, because there is no real data center. There's no data they've been collecting. And I think the best way is to get into these communities and talk to them about what they need. You know, I get data, but with the absence or with the paucity of data, like less data is almost less helpful than too much, right? And so I find that going to these communities and starting with what do you need makes so much more sense. They'll participate in your programs. I mean, some of these communities have full centers and they don't go. They don't go. They don't go because they make a day of going to Las Vegas or going to Reno. They have a whole activity and they trust their doctors. They're not going to change their patterns just because you drop a doctor into the community. And we learn that the hard way.
Yeah, because it seems intuitive to me, like put the doctors located as an easy access point, but they don't want to go there.
Right.
Wow.
I've learned so much. I mean, I even talked to communities and I said, you know, we want to put in Narcan for substance users. You know, their belief is they don't have that community in their community. There are no people with substance abuse disorders. Okay. So it wouldn't go over well if I dropped a substance use clinic
Right.
into that community when, you know, the commissioners and people really don't support and believe that perhaps might attract. And again, we have to deal with the realities of the rural communities. And if there's anything else I can tell people is don't think you've got to ask these communities because they will just block you out. You'll spend all kinds of money to do things and they just won't attend.
Yeah, and I assume like a change or shift in culture takes extremely long, if possible at all, to make.
Right.
To get that, to establish that trust. And then even then there's turnover of people, which
Right.
makes it very hard to maintain that trust.
Exactly.
Yeah. So I've heard that there's just also a lack of like personnel to fill these roles within health plans. Maybe correct me if I'm wrong. So what you're telling me about seems like it takes so many people to make happen. Is this a part of the challenge? Like, do you have people who are like, how many miles did you say they cover? Like able to do that in an effective and efficient way?
No, workforce shortages is extraordinary. And so, you know, creating new opportunities for community health workers, for peers, for community paramedics. In Nevada, we expanded the role of all three of those positions, so they're now reimbursable. And what we're looking to do is to go into communities and do training programs. We are not.
So they could be the ones asking the questions to the communities and hopefully starting from a place of trust and understanding. Like, it sounds brilliant.
It's, you know, one day, it's funny because you put it on paper. We're going to go out there. We're going to hire people. We believe, just like you said, if they're from the community, that's who should be talking to the community about the community and understanding the community. That's the model. Again, we may find we're not able to find enough people. And then we may look at matching, you know, trying to find people that are like to the community. That's sort of the second step when you don't have people. And then we are going to be bringing in providers, you know, whether it's virtual like you all, or whether it's some providers we have that will become safety net providers. So if you go to, we have, I call them safety zones. Those are what I was mentioning about for our pregnant women. And really anybody in crisis, but we'll have safety zones. Well, at those safety zones, we're going to have physicians 24/7 that will be able to help people in crisis. I mean, that just takes straight dollars to man a line. But again, people have to go there when they're in crisis, and that's where we have to build the relationships.
Right. So there's things I'm trying to work out in my head, because a lot of this, ultimately a lot comes down to money in the bottom line and like how to sustain this. I might not formulate the question right. I might need help with this, but if what you do, bringing all this care in the best way possible to the communities, is it's a lot of preventive care, a lot of avoidance then of ER visits that are things that become emergencies that don't have to be, or repeated ER visits, maybe just because of lack of access from like nearby community. That would mean that hopefully you're saving tons of healthcare dollars down the line, but in the immediate future, you're going to create a decrease in profit for whoever's going to miss out on these ER visits. So let's say like health systems. How do they respond to this? And now we're probably getting into like the fee for service versus a value-based care model. Is there maybe, and again, I might need your help structuring this, like what is the system like now versus maybe how it should be within value-based care? Or like, how do we save healthcare dollars and do this the best way possible?
Well, I think for clarity, it's that the way we used to practice was C1 pay one, C1 pay one, C1 pay one. And so what you're talking about is if we start taking away some of those C1 pay ones, what happens to those entities, hospitals that we're taking those people away from,
Right.
which is great, brilliant. Couple things. One is usually those people are uninsured. So unless you're a hospital that has benefits around the uninsured, they don't mind not having that population. Second thing is inappropriate utilization of the emergency rooms is going to be unfunded. So as we go forward, if you're just taking people in because, admit you think, you thought about yesterday, whatever, they won't get paid anymore. So the healthcare system is helping us a little bit, but the incentive is to get those individuals back to us, because what will happen is they won't be able to be seen in the ER, or they'll be seen and then turfed, and we need those people back so they don't just go back to the ERs. So I see that as the value side, is let's make the process better as opposed to valuing what shouldn't be an ER visit anyway. They needed to lose those. That was inappropriate utilization of the emergency room. So that piece, I think we're going to be okay with. The part about, when you really get sicker, I don't know a hospital system that will openly say they want to have people get sicker. So they have to fundamentally get, we're not going to let people sit out there and get sicker so you can have an ER visit. That won't work. Mm-hmm. So I think that that's where value-based contracting comes in, because we can say, help us fix the system. That's where I see value-based. So drive to outcomes, but help us fix it. I'm as incentivized to tell somebody, send that person back to me as send them to a referral, because I know if I refer them, I'm going to help them get there. If you refer them, you're not going to. The other thing I will say is that Medicaid is being funded. And again, this may change because, every election time things tend to change, but Medicaid has taken on those social determinants around and lieu. So they're taking on funding for some elements of housing and food. Non-emergent transportation has become a managed care problem. So we are now responsible to pay. Now, that's why I love working for a nonprofit, because it's beautiful. Yeah. It's okay. The bigs, this is going to be a tough transition.
So I'm so curious, what it is fundamentally, tangibly, what's the difference between the nonprofits and what'd you call them, the bigs?
Yeah, the stock is the biggest change. We have no stock, no investment portfolio, no stockholders and shareholders that we speak to. So that's one. The key is our investment models. So we don't have the profit margins that the for-profits do. And so we reinvest, like, for example, the reinvestment in Nevada is around 3%. We're offering up closer to 10% because that's what we do. We reinvest and I mean, don't get me wrong, people are making money off a good business, but it's very different than the for-profit model for investing. The other thing that we're able to do is take advantage of the nonprofit benefits. There are some incentives around dollars, working with nonprofit partnerships, so those are also better. Our company was started by a social worker. So our big gig is
That's so
what
cool.
we call life services. It's social determinants as a driver of healthcare. So all of that is possible because of the nonprofit status. We don't feed money back to stock shareholders. We look at community investment. It's a very different investment portfolio and dollar use.
Okay, gotcha. So like anything, any margin that you're making off of services or like money saved, you're putting back into more services versus making a profit off of them, or
Yeah.
stockholders making a profit off of them. Okay.
You take the
That sounds
stockholders out of the picture and that money is available because, our leaders still get their benefits and profit and all of that. But you take the whole stockholder piece, there is none. So all of that is up for reinvestment and reincorporation into care delivery.
that sounds lovely.
It is. It's really cool. I've tried twice into for-profit managed cares and for different reasons. But this is a different approach. I wouldn't have gone to the rurals with the others because of the need for the big investment, like you've been mentioning.
Wait, say that again. You wouldn't have gone
To expand to rural Nevada with a for-profit because there's so much investment that needs to happen. We need a vehicle for that, and we need a vehicle for collaboration with other nonprofits, and that doesn't exist in the
Oh, that's interesting. So you basically get more access to other resources, or you feel it's more effective to do it through a nonprofit.
It's effective. It's not really more, but when I say to a nonprofit, "Hey, I'm a nonprofit too," they're not thinking, "Oh, you're a big
Right, you're in
managed
it
care
for the money.
plan," right? They're saying, "Oh, okay, well, we can relate." So it's that more than true access. Like there's no contract that exists because we're both nonprofit, but it's totally different when I go to a nonprofit and say, like Doula Association, when they work with a nonprofit healthcare, at least they think this might be better, and it is.
Good. All right, so I'm going to shift a little bit. So what are some of CareSource's future goals and plans, both for Nevada, maybe overall, in terms of advancing health equity and innovation?
Cool. So CareSource is doing some really amazing things. We are looking at special populations right now and building some special programs. So foster child welfare is a big area for us, really trying to specialize. We have some great experts as part of our team that have been working in this area. So doing a lot of work with the population and doing reentry with our criminal justice. Those two areas we have really, the Centers for Medicare and Medicaid are now going to require reentry as a part of our program in managed care. But we've been doing it. So it wasn't because of that. I like to say, no, we really believe, because this is a population, again, not being addressed, likely not insured. So we want to get them into the program and then really start to work with them. So reentry is coming. And long-term supportive services. I think disabilities and individuals with disabilities is a sweet spot for us. Again, I think it's heritage and what we believe in and how we believe, but we're really moving in that direction as well. Some of the states like Nevada, they keep that population. So here we won't be focusing on that, but that is a corporate initiative for CareSource. And then AI, what's going to happen? We don't know. I'll be honest with you. We don't know. What should we be doing? Should it be that docs are looking up and trying to find answers? We write proposals. Should we be using AI to write proposals? So I think AI is definitely in the mix. We've automated a number of our processes. The other thing that CareSource is really great at is provider efficiencies. We want to be the fastest to pay your bill. We'll clean your claim for you. We'll help you get paid. We'll, give you support if you need it. But the provider barriers is really what we're working on reducing, so that they don't see that from us, so that docs get paid right away, providers get paid. And then the last thing I would say is that we're looking at creating networks of community-based organizations. I have I've done this once. It's very challenging, taking organizations that have been getting money from grants and trying to help them to build a system, big culture shift. And so we're trying to create networks of support like we have for docs and nurse practitioners, for community organizations to help grow them so they can take on some of these big roles, like providing food for everybody in Michigan, essentially. Not really, but you know what I mean.
Yeah. Wow. So what advice would you give to other healthcare leaders looking to make a meaningful impact on health equity?
Listen. Stop talking. Listen. Because like I've said so many times, I've been burned before. You cannot assume you know. I know assume is like, you cannot assume or maybe you are right, but you've got to ask before you make a change. And that relationship building is critically important. It's more important than your knowledge. You can go to 100 years of school. It's about when you're talking to people. And I would tell people to qualify those skills, like get good at meeting people and listening, hearing what they need, what they want, what the community has tried and failed. But don't assume, because you'll likely be wrong. Any
other topics that we didn't touch on that you'd want to talk about?
I just want to focus on the family a little bit, Lindsay, because we've changed the families in our world. And I think we have to get better in understanding the dynamics of our family relationships. Like, things have really changed. And so the old traditional roles and everything, that's the other thing I think we need to broaden our horizons in what the way people are living, what families look like, where the grandparents are, where they aren't. But I hope we can end on, like, it's not a person, it's a family. It's the entity. Like, just talking to a 10-year-old, like, if you don't talk to mom and grandma and dad and the sister, you're missing a lot. So that's the only thing. I just don't take things out of context, because it's often not complete.
Yeah, that makes a lot of sense. Absolutely. And what's the population like in Nevada with Native Americans? And because I know that you're working with them as well, and they probably have specific needs, and I'm curious to learn more about it.
Yeah, well, we have I want to say 16, but I could be a little off, tribes here in Nevada. It's a large population here. And what I will say is they're the perfect example, Lindsay, of not thinking you know. They're the perfect example of learn about their community, learn about the way they are practicing, and then give them opportunity to fill gaps, not to supplant or to vary or to give them something else. Listen and learn. For example, did you know that community health workers were established by the Native American communities?
No.
And that for 50 years, they have been using community health workers. They call them a different name, and they're fully funded, and they're given to different communities. So one of the ways we are working with the Native American community is learning from them the opportunities that community health workers have given their communities. Entering that way, Lindsay, 100% different than we'll drive you to a food bank and we'll provide you with, incentives. No, it's like we're asking them to teach us. Boy, I'll tell you, it was a total mood shift. We participated in the powwow and we brought a table, and they never knew
Wow.
about managed care, but we didn't ask them to have a powwow for us. We went to their activities.
That must have been
So
incredible.
for us, that's what we do with communities. It's listen and learn from them, and then offer up solutions. Because boy, when we said, we can give you some assistance with transportation to the specialty clinics, they were really interested in that after they knew we weren't there to change their life.
Right. You establish a trust, and going back to what you said earlier, it's about the relationships, it's about the people, about the family, their core values, and meeting them where they are.
Exactly. Well said.
I am learning from the best.
We're a team in this.
Yes, true. Absolutely.
It's everybody. But I've learned a lot about communities of need. Our community of color here is very challenging because we need to be better at addressing their needs, and we need to listen. So there's a lot of work to be done. I think when we get into Medicaid and can make some changes here and develop a rural strategy, my hope is that we can take it to the West Coast, that I can start moving this type of strategy through CareSource to the West Coast so we can start really making some changes. And, you live a big dream.
Yeah. Well, I hope so too. Well, thank you so much for joining us today. I've learned so much. I've enjoyed so much chatting, and just so appreciate your time. You're doing such amazing things.
Well, thank you. Thank you so much. I've really enjoyed the time too. I look forward to our future relationship, and CareSource is coming, so we're excited to be a partner with you. So thank you.
Thank you all for tuning in to today's episode. Be sure to subscribe to the show for more episodes. And if you love the show, if you haven't already, please be sure to leave us a 5-star review.